Okay, thank you, Clint. Good morning, everyone. This is Nizar Waibi. I'm the State Health Officer, and I would like to welcome you to our State Health Council meeting, the first for this year. As a starter, I know that many of you have joined or were appointed to the State Health Council recently. So it would be nice to go around the room and go through a brief introduction. So in order to kind of like manage, I'll follow the list that I have with me. So we'll start with Daryl.
Yeah, good morning, everyone. It's nice to be back in a meeting again with the Health Council. I'm Daryl Birch. I'm a retired CEO of Sakakawea Medical Center in Hazen and also Coal Country Community Health Center in Beulah. I'm still participating in healthcare by doing some consulting for some different entities, and I serve on the Blue Cross Blue Shield Board of Directors.
Okay, welcome, Daryl. Thank you. And Sherry Adams.
Good morning. I'm trying to get my camera fixed. I'm Sherry Adams. I'm the Executive Officer for Southwestern District Health Unit. We cover the 8 counties in the Southwest, a local public health unit. Also President of the State Association for City County Health Units at this time, or what we call SACHO. I recognize quite a few people around the camera, and so it's a pleasure and an honor to be on this group. And I look forward to working with you and learning even more.
Okay, welcome, Sherry. Thanks for your service. And Kevin?
Good morning, everyone. My name is Kevin Dufany. I'm Tribal Health Director of Spirit Lake Tribe. And as well as I'm honored to work with some of you. And this is my background is human resources. And so this is something new working in the healthcare field.
Okay, welcome, Kevin. Daniel Churchill, I think, yes, Dan. I think you're still muted, Dan. Okay, so we'll give it a try, Dan, and if it doesn't work, we'll get back to you again. No, we can't hear you. Okay, so we'll come back to Dan in a sec. Let's go to Mary. I thought I saw Mary on. Yes.
Hello, everyone. I'm Mary Gumke from Watford City. I am the Executive Director of the Watford City Area Chamber of Commerce. Born and raised in North Dakota and excited to be on this council.
Thank you, Mary. Nice to see you, and thank you for your service.
Thank you.
We'll go. And I saw Missy earlier.
Yep,
Yes.
I'm here.
Hello.
Yeah.
Mm-hmm.
Hi, my name is Missy Hankey. I am the Medical Director of the Heartbeat Foundation. I'm also the Medical Director of the North Dakota Professional Health Program. We work with physicians, PAs, medical students who struggle with mental illness and substance use disorders. So that's kind of where I live. Thank you for letting me be part of this.
Sure. Thank you for your service, Missy. And Carrie Ann.
Hi, I'm Carrie Ranum. I'm a pediatrician in Hettinger, North Dakota for West River Health Services, and I serve our 4 outlying clinics too, providing care down there. And me and probably my husband Josh Random also works down here, and we have 3 little girls. And I also serve on the kids special needs board too for the state.
Sure, thank you. And Mark Strand.
Hi, everyone. My name is Mark Strand. I'm here at North Dakota State University. My certification is in certification in public health. I work as an epidemiologist in chronic disease epidemiology, and involved in both the School of Pharmacy and also the Department of Public Health here at NDSU in education and research. Look forward to working together with you all to serve our state.
Okay, thank you, Mark. And Dan, we'll give it a try again.
Okay, can you hear me now?
Yes.
All right, sorry about that. I am Dan Churchill, pharmacist at Churchill Pharmacy in Bismarck. And we also have 4 rural telepharmacies around the state. And so have a special focus on healthcare access in rural North Dakota.
Okay, perfect. Thank you, Dan, and thanks for your service. And thank you all for providing your time and expertise and resources as we bring the State Health Council to our work with the Department of Health. So the second agenda item, which is also as important as the first one, is to go through election of officers. And, you know, I kind of like, it will be a remiss to kind of like not go through other participants in the meeting. I know Allison is on the call. So Allison, would you please go ahead and introduce yourself?
Hello, everyone. My name is Allison Hicks. I am an Assistant Attorney General with the Office of Attorney General. I serve as the General Counsel for the North Dakota Department of Health and the Health Council. So if you have any legal questions, I would be the one that you send them to.
And we thank Allison for her guidance in every aspect that we ask for her help. She never says no. Yes, so I'm looking also, there are a list of participants, but I want to also to cover Miranda. Also, she is our contact person. Miranda, would you just introduce yourself, and because you are the contact person with everyone?
Yes, you will. I'm Miranda. You will be getting emails from me. I'm the person you'll contact if you have any questions. So it's nice to meet you all. I'm Dr. Weeby's executive assistant, and I've been working here for about a year now.
Okay. Okay, thank you, Miranda. Okay, so let's now go to our second item, which is election of officers. And for that matter, we will need to elect chairman, vice chairman, and secretary to allow the council to kind of function as a body. So we'll just kind of start with the position of chairman, and we'll kind of like seek or wait for nominations, or if someone wants to self-nominate or someone wants to nominate someone else, that also is possible. Okay.
Would it be possible to revisit the roles that are associated with those?
Sure. So
what officers are needed and then what roles are associated with them?
sure. Okay. Allison, is that something you can kind of like advise us on?
Sure. So you would need a chair, a vice chair, and a secretary. And I'll go through the kind of obligations of each. So the chair usually is responsible for presiding over the meetings. You'll likely work with Dr. Wiebe and Miranda to approve any agendas before, you call the health council meetings. And then you just generally kind of run the meeting, call for motions, that type of thing. Vice chair, basically, you're a glorified sub for the chair. So you have a position, but you don't really do a whole heck of a lot unless for either due to conflict or absence, the chair is unavailable to run the meeting, approve the agenda, that kind of thing. And then you have the secretary who will generally likely work with the Department of Health staff to solidify and sign the meeting minutes. So you'll make sure that the meeting minutes accurately reflect the meeting. And then at the next meeting, once the Health Council approves the draft minutes, then you would sign them. So fairly rudimentary, you guys. The Department of Health does most of your licensure issuing, that kind of thing. So the responsibilities are a little bit less than some of the other state boards that do the same things.
And Sherry, you have a question?
No, I just would offer that I would do vice president or president unless somebody else is jumping at the bits.
Sherry, you're offering to be nominated as chair?
Chair or vice chair, unless somebody else wants to do it. Not that I'm nominating myself because I'm wonderful, but.
I'll second your nomination as chair.
This is Daryl, and I served on the Health Council last year, and I again would also be open to any kind of position where I can be of service to the council.
Allison, just quickly for procedural purposes, do we vote on each position or is it a slate? And
No, so you're not running like a ticket where it's like,
okay.
Daryl didn't say he'll only be vice president if Sherry is the president or vice versa. So I would vote on each position, start with the chair, and then work your way down.
Okay, perfect. So so far we have Sherry who's been nominated for a chair. Any other nominations? Any other nominations? Do we do it thrice, 3 times? Robert's Rules of Order? Or
So
yep, call for discussion 3 times.
I would make a motion that we cast a unanimous ballot for Sherry as the chair and have nominations cease. If that's the correct Robert Rules of Order way.
You know
Okay.
it.
Okay, so the motion was to cease nominations and cast a unanimous ballot for Sherry Adams as the chair.
Second that motion.
Okay, it's been moved and seconded. All in favor, say aye.
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 Any opposed, same sign. Okay, Sherry Adams, chair. So let's seek nominations for vice chair.
I nominate Daryl Birch.
Okay, so Daryl Birch has been nominated for the position of vice chair. Are there any other nominations? Any other nominations? Any other nominations for vice chair position? So hearing no more nominations, is there a motion to cease or stop nominations and cast a unanimous ballot for Darrell Birch as vice chair?
I move to close nominations for vice chair.
Okay.
Second.
It's been moved and seconded to cease nomination and cast unanimous ballot for Darrell Birch for the position of vice chair. All those who are in favor say aye.
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 Any opposed, same sign. Darrell Birch, vice chair. And now the position of secretary, it's open for nominations.
Allison, can I clarify again? Secretary is basic. Does that mean taking minutes at the meeting as well? No, that means signing off on the minutes that were taken by the staff support. Is that right?
Correct. My understanding is that the staff will do the minutes based on the discussion, and then it'll be presented to you. You'll basically edit them for presentation to the Health Council. You're not actually taking the notes. No.
Thank you.
That being said, I think Mark has a really nice signature, so I would nominate Mark for the position of secretary.
I will second.
Okay, so Mark Strand has been nominated for the position of secretary. Are there any other nominations? Are there any other nominations for position of secretary? Any other nominations? With that being the case, I will entertain a motion for stopping the nominations and casting a unanimous ballot for Mark Strand for the position of secretary. Is there a motion?
This is Sherry. I'll make that motion.
Second.
Okay, it's been moved and seconded for that Mark Strand would be elected for the position of secretary. All those who are in favor say aye.
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 Any opposed, same sign. Okay, so Mark Strand, secretary. So with that, now based on your vote and elections, Sherry Adams has been elected as chair of the State Health Council, Darrell Birch, vice chair, and Mark Strand, secretary. So with this, with the officers being in place, I will yield to the chair, Sherry Adams, to take over the procedures of the meeting and the agenda. Sherry?
Thank you, guys. And I obviously will need some help in this role at the state level. So the next item on the agenda is the approval of the May 12th, 2021 minutes. I know they were sent out by Miranda. If you guys have had a chance, those of you that were present, to look at those, and if somebody wants to make a motion to approve those.
This is Allison. I just want to be clear. All of you have to vote on the meeting minutes, whether or not you were there. Okay. I think only 2 of you would have been there. So all of you have to vote, you know, look for typos, that kind of thing. Everybody votes.
Thank you, Allison. So does somebody want to make a motion to approve the minutes that were sent out?
This is Darrell. I would move to approve.
Second.
Darrell, thank you. All in favor say aye.
Aye.
Any opposed? Same sign. No. Okay. We will go now to Allison, who is going to go over the role of the State Health Council and orientation for all of us new people.
All right, so bear with me. I'm going to try to share my screen. I practiced this last night. I'm hoping it works. Can you guys see my PowerPoint presentation? Okay, perfect. That's a great start. Okay, so like I previously said, I am the general counsel for the North Dakota Department of Health. That means that I am your general counsel as well, but my employer is the Office of Attorney General. I have several other clients as well. So in this PowerPoint, we'll generally talk about the structure of the State Health Council, the powers and duties that you guys have both pre and post August 31st, 2022. And then we'll talk a little bit about voting and some issues with that. So the structure of the State Health Council, generally you guys are made up of 9 members. 4 of you come from the healthcare field. 5 of you come from trade, professional, or consumer organizations. You're all appointed to 3-year terms. I believe the majority of you are just being appointed in 2021, at the end of 2021. And then the remainder of you are holdovers from, I believe, 2020. All of you are appointed at the governor, so you serve at the pleasure of the governor. And then, like we just did, the officers get appointed annually, and those are your chair, your vice chair, and your secretary. We just talked about the duties of each of those positions, so we'll make this brief. I'm sure you guys are going to have a long enough meeting today. I won't go into those again. As you guys are members of the State Health Council, you do receive some compensation for serving on this board. If at some point in the future we move back to in-person meetings, you would receive expenses, so travel, lodging, and food expenses. Those follow your OMB fiscal policies. Generally, that's fiscal policy 503 and 505. You don't get any of that for online meetings. I just want to clarify, it has been asked before. You do get compensation, daily compensation, while you are attending council meetings or in the performance of any special duties that the council may direct. And some of those may be, if we call a special meeting, you get compensated for that. If somebody has you working on some large rules package or something like that, and it takes up a majority of the day of your time, you can charge for that as well. You get the per diem that is set for the legislative members, and that right now is $189 per day. It's $193 after June 30th. I just want to be clear, you cannot be paid if you are a state employee, an employee of a political sub, or any institution or industry operated by the state. This would be, for example, if somebody worked at the state health or the state hospital or something like that. That would be the equivalent of that. So now that you're on the Health Council, all 9 of you, what are your powers and duties? So this is generally going to be available to you in 230103. I see Mark has a question. I'll just do questions throughout. So
yeah, is NDSU considered a state agency? Therefore, do I receive the per diem or not?
I'll talk to the university systems. For some things, you guys are considered state employees. My gut says that you are, but I need to talk to Eric Olson, is the university systems, and I will see if, for the purposes of state board membership, if you are considered a state employee, because you guys are this weird 4th constitutional body.
Sure.
So nobody's sure.
No problem. Just wanted to alert you so that I can clarify it ahead of time.
Yes, I'll follow up.
Thanks.
So your powers and duties are generally set forth in 230103. This is the North Dakota Century Code. These are available on the legislature's website if you are unable, or else you can just Google North Dakota Century Code and it'll pop up. So in 230103, it says the State Health Council shall, so you set your own meetings. You make rules for your own basically governance, which there's not a whole lot. You guys just kind of generally roll with Robert's rules. You guys don't really have any special governance rules or laws. You establish standards, rules, and regulations which are necessary for the maintenance of public health, including sanitation and disease control. Usually those rules, standards, regulations will be proposed to you by kind of the subject matter experts at the Department of Health as needed. It's not kind of up for you to just kind of determine what those are on your own. So this means that you are in charge of passing administrative rules, and usually those rules are all related to the Department of Health. So all of the Department of Health's admin rules will run through this body. You will see that later today. The next kind of big duty is to develop, establish, and enforce basic standards of hospitals and related medical institutions which render medical and nursing care, and also for the construction and maintenance of those institutions. So again, you will see standards. Those standards are generally set by administrative rule, and then I'm sure that will be presented to you by the subject matter expert. I believe Tim Wiedrich is generally kind of the facilities person at the Department of Health, that he's the division director for that. And then you do issue some licenses. For example, the Department of Health manages the nurse aid registry. So you will hold hearings on matters brought before you by either applicants for licenses, and that's either licenses for professions like the nurse aid, licenses for medical hospitals or facilities. And then you will also hold, we call them generally disciplinary hearings. So if the department recommends or actually denies, suspends, or revokes those licenses, then usually there is an appellate function. You guys are that appellate body before it gets escalated further. I do want to make note. So as of August 31st, 2022, so coming up later this year, the Department of Health and the Department of Human Services are going to be merging. And so there's going to be a restructuring specifically of the Health Council's jobs. And so these are your jobs until August 31st, 2022. After that, you no longer will be making any rules. So all of that will likely be done by the agency head of the Department of Health and Human Services. It will no longer cycle through the Health Council. So that's a big part of your responsibilities. You still can set standards and regulations, which are essentially policies, but kind of the heavy hitting things all need to be an administrative rule. So likely we will see far less of that going into the third quarter of the year. You will still do the hearings though. So again, what are the big kind of tasks of the Health Council? You make rules and you hold hearings. Those are kind of the two major arms. And then come September, you no longer make rules. So you will mostly just be responsible for holding hearings. And then you will find scattered throughout the Century Code, there are just random references to things that you have to make and approve rules for, or you have to hold hearings or generally administer. So the first large category of that is going to be loan repayment programs, which I believe we'll see later on the agenda today. There are 4 big loan repayment programs that the Health Council administers: the Healthcare Professional Student Loan Repayment Program, the Veterinary Loan Repayment Program, the Dentist's Loan Repayment Program, and then you also manage a long-term care nursing scholarship and loan repayment program. You randomly license and set rules for electrologists and electronic hair removal. Vector control districts, which is like kind of your mosquito districts. Alternative healthcare services pilot projects. So generally what that is if there is a determination by an area of the state that they are rural and underserved medically, they can kind of come up with alternative healthcare solutions, and then they apply for your approval to run a pilot project under this specific century code. And then you also approve and review loan applications for loans from the revolving fund for construction of basic care and nursing facilities. Does anyone have any questions about what your job, your powers and duties are as health counsel? Yes, Sherry.
Is there some way that we can get a copy of these so that we have it?
You bet. I can send it out after the meeting is done.
Thank you.
So next we'll go into voting. So I imagine a lot of you have dealt with a lot of boards if you work in healthcare. So a lot of this is probably just going to be refresher, but we'll go over it anyways because it makes me feel better that I said it to you. So you have an obligation to vote. That is what the governor appointed you to do. The only time that you can abstain from voting is when you have a proper abstention. All votes of the Health Council on substantive matters need to occur in open session in the public, and all substantive matters need to be roll call votes. So, for example, we did voice votes for the chairs, that's fine. But when we move into approving admin rules, all of that's going to need roll call votes. Anything dealing with money, so the loan repayment programs, all of those are going to need to be roll call votes. Usually I only let people do voice votes for procedural votes. So like a call to question or closing a discussion, or minutes, and then procedural stuff like officers, unless it's super close, and then we'll break that down into roll call. So the question then becomes, what is a proper abstention? Well, the first thing that we look at are conflicts of interest. And so this is a very unsettled area of law right now in the state of North Dakota. There is no statute specifically for state boards. The only rules for conflicts that you will be bound by are those from the North Dakota Ethics Commission, which they are currently working on drafting their generalized conflicts rules, but those have not been finalized to date. We will talk about the constitutional provisions that you are subject to as Health Council members. So generally, when I talk about conflicts of interest, because we don't have actual statutes or ethics commission rules right now, we're going to talk about best practice, and that's the best practice that has been determined by the North Dakota Attorney General's office. So when can or must a board member abstain from conflict? And what we have adopted is the rule for political subdivisions in quasi-judicial matters. You'll find this in North Dakota Century Code 440408. And that is when a person has a direct and substantial personal or pecuniary interest in a matter before the board. And then I've included, but I will not review because nothing bothers me more than when people just read off of slides. Those are the definitions that the Attorney General's office, as well as the North Dakota Supreme Court, have adopted for direct, substantial, personal, and pecuniary. I want to make clear, just the appearance of impropriety or a potential conflict of interest is not something that you can abstain from voting on. So oftentimes we will find that some people will feel awkward and they will abstain from voting, or they may personally, like for example, if you are disciplining a CNA license and the CNA is your parents' neighbor and you're like, man, that's going to be awkward. Awkward is not an appropriate reason to abstain. Discomfort is not an appropriate reason to abstain. Like I said, you guys are subject to regulation by the North Dakota Ethics Commission. You are appointed officials. For conflicts of interest, the main thing that right now is applicable to you is Article 14, Section 2, Sub 5. And this only relates to quasi-judicial proceedings. So this would be when we hold hearings. So if we have a hearing on a license, a hospital license, anything like that, anything where you are making a decision on somebody's general property or other rights, that is going to be a quasi-judicial hearing. And what Article 14, Section 2, Sub 5 states is directors, officers, commissioners, heads, or other executive of agencies shall avoid the appearance of bias and shall disqualify themselves in any quasi-judicial proceeding in which monetary or in-kind support related to elections, which I don't foresee that being a kind of an issue with you, or a financial interest not shared by the public as defined by the Ethics Commission, which currently is not defined, creates an appearance of bias to a reasonable person. And so you would have to recuse yourself. So for example, say one of you is, and this would never happen, but one of you is fully personally funding a hospital. And all of a sudden we're having a hearing on that hospital's license. This would be one of those financial interests that you would have to recuse yourself. The Ethics Commission is formulating rules to provide clarity, but I do want you all to be aware that number one, you are subject to regulation by the Ethics Commission because you are public officials. And number two, as it relates to voting and conflicts of interest, this is currently in full force and effect. It just doesn't have a lot of clarity from rules. And if you have questions about this, let me know because I'm general counsel for the Ethics Commission. So generally, as a procedural issue, you have a conflict of interest. What do? As soon as you have a conflict of interest, you let me know and you let your chair know. And the reason for that is I need to do research and work with you to determine the specific facts to determine whether or not you can actually appropriately abstain from the vote. And then when we get to the meeting, at the beginning of that agenda item, you will disclose your conflict. You don't need to go super in depth, but you need to provide enough factual basis for the commission to make an educated determination on whether or not you have a direct and substantial personal or pecuniary interest in the matter such that you should abstain. The council will decide, again, because this is substantive, by roll call vote, if you can participate or vote in the matter. And so if they allow you to vote, you have a duty to vote. So even if you don't want to vote, you got to do it. If they vote to require you to abstain, you got to abstain. And when I say abstain, I mean you don't participate in discussion. This is a problem for me. You control your face and your like general mannerisms. And you don't influence the vote in any manner. So you are totally out of it. You are under no obligation to leave the meeting. You just cannot participate in it. So for that specific purpose, it's as though you are no longer a health council member. And then if it's a proper abstention, then you are recorded as having abstained from the vote. But if it's an improper abstention, say you're just super uncomfortable voting on your parents' neighbor's CNA license, you're just not going to do it, no matter how much. Either way, you get voted with the majority. So you just then no longer have a voice in the issue. Does anyone have any questions on this procedure? I don't think it'll come up a whole heck of a lot for you guys, but I just want to make sure you know what the procedure is. Mark.
So did I hear correctly that we are technically considered public officials in our capacity serving on this board, on this council?
For the purposes of the Ethics Commission, yes, it is a limited determination under the definition of the Ethics Commission because you are appointed by Governor Burgum.
Okay, thank you.
Yes. The last thing that I kind of want to briefly touch on before I finish is open meetings and open records. You guys are a governing body, so you are subject to open meetings requirements. So that means that any quorum of you, so any 5 members, cannot discuss health council business unless it has been a properly noticed meeting. And in regards to noticing meetings, Miranda does a fantastic job with that. She notices all the meetings, but this means if for some reason all of you are at a conference or something like that, you all just can't go huddle in the corner and start talking about health council stuff. And I'm just going to do a broad overview because, again, I don't think this will become an issue. But you cannot discuss anything we do have to discuss. Like, for example, if stuff comes up in a hearing or something that ends up being confidential information, you do have the authority to go into executive sessions as long as we properly notice those. But that's something me, the administrative staff, Dr. Wiebe, and the chair will likely troubleshoot as the agenda gets approved by everyone, and we'll put it on there so it'll be properly noticed. In regards to open records, anything that you have relating to the public business of the Health Council is an open record unless it qualifies for an exemption. So, for example, if Carrie is taking copious amounts of notes during this beginning of this meeting, and she decides to hold on to those notes are open records. My PowerPoint, open record. Anybody can call Miranda or Dr. Wiebe or any of you and ask for a copy of it, and it is open to the public. Any of your emails are open records as long as they relate to the Health Council. I know a lot of you are probably, you guys are all related to health stuff. I'm sure you guys have sensitive emails. I'm only talking about the emails related to the Health Council. So even if you send something from your personal Gmail, your whole Gmail isn't open to subject to open records. It's just those related to the Health Council. It does not matter who you send those emails or text messages to. If I talk to my sister about what the Health Council did today in an email, that email is subject to open records. It is about public business and I hold it. So just be careful and cognizant of some of that stuff. There are records retention laws related to some of your correspondence. But that's all stuff that if you just have questions about it, contact me. I'm sure Miranda knows as well. But yeah, otherwise that's just kind of a quick and dirty open records, open meetings. You are subject to it. Just be aware of it in the back of your mind. Mark.
So if I am taking notes at this meeting, if there was a request for open records, is it only if they would ask me to turn that over, or is that something that I have to voluntarily turn over if I was to catch wind that, oh, somebody's asked for minutes from health council meetings?
So
What's
the way
rule
that,
on that?
so typically the way that this works is likely someone would contact like an administrator, a chair. They might contact Dr. Wiebe or Miranda, and they'll say, I want all records of the board related to the March 1st, 2022 meeting. Then it becomes Miranda's obligation, or whoever receives the open records request on behalf of the Health Council, we will circulate it to every single one of you. And we will say, hey, if you have materials from the March 1st, 2022 meeting, you need to go ahead and send that to us. And that's how we will let you know. Because you guys are a governing body, every single time we get records requests, it will be sent out to the whole group. Now, if there's no record retention law or policy that the Department of Health has on notes, which most agencies don't have, then If you are just a habitual anxious note taker and you just like to write and keep your hands busy during a meeting, there's nothing preventing you from throwing those notes away. Again, that's something that we'll have to look into with Miranda, but the crux of this is somebody will always tell you when the health council gets an open records request because you're a governing body. So we have to check with every single one of you.
Thank you.
Yep. Other than that, that's kind of my spiel. Christy, yes.
What about those of us that are just kind of observing, that aren't on the actual council but watching? Do we get notified of those?
No, this is only it's only the governing body. So you would, Christy, because you are an employee of the Department of Health, if the Department of Health got a records request that said, I want any and all records that any employee has about the March 1st meeting, then yes, you would be subject. If the open records request is sent to the Health Council, though, just because you attended a meeting as an observer does not make you subject to those open records requests. But it depends on, because you are still a public employee, it depends on what entity the open records request is made.
Thank you. Appreciate it.
Yep. Again, this is my email and my direct phone, my direct office line. So if you guys have any questions or concerns, any follow-up questions that you're not comfortable asking in an open meeting, just let me know. Those are the best ways to contact me. So other than that, you can move on.
Thanks, Allison. That was very informative and a good review for those of us in healthcare. All right, so we will tag on to that and go into some of the administrative rules. I know those were sent out. One was on medical marijuana and the other was on vital records. So we will turn the first one over to Jason, who's going to touch base on some of the highlighted things that I'm guessing he wants changed or brought to the group.
Thank you, Madam Chair, and good morning, council members. My name is Jason Wall. I'm with the Division of Medical Marijuana in the Department of Health. We do have some proposed changes here for your consideration to review. I'll briefly discuss certain changes. Happy to provide more information on any areas that I don't cover or didn't address as well. Before I begin covering the changes, I did want to discuss certain terms that you're going to see as we kind of walk through the rules this morning. One of those terms is compassion center. A compassion center is simply a term that was established in state law when the program was established, and a compassion center is a manufacturing facility and a dispensary. Now, a manufacturing facility specifically is an entity that does all of the growing of marijuana in the program. It harvests all the plants, it does the processing, producing, and packages all the products to be transported to a dispensary. There are two registered manufacturing facilities in the state, one in Bismarck and one in Fargo. A dispensary is an entity that receives those prepackaged items from the manufacturing facility and sells products to registered qualifying patients. There are 8 registered dispensaries located in the 8 major cities across the state. Madam Chair, you did mention that all members have the PDF document of the rules with proposed changes. With your permission, I'll just reference page numbers of certain changes and kind of start covering the changes in that manner.
That would be great. And then I do have a question for Allison. Do we vote on these separate changes one at a time, or do we vote them all together, or no?
No, you would vote on them all together just to accept his rules package.
Okay.
If there are specific things that you don't like, that you want him to go back and change, then that would be the motion. But otherwise, no, some of that would get real tedious.
Thank you. That sounds good. Okay, you can continue, Jason.
Thank you. I'll start then going through certain rule changes here, beginning on page 3. of that PDF document that you should have. Here, there's a proposed change to the definition that allows the department to provide more time to manufacturing facilities to process products if it's determined necessary. Typically, it's a 48-hour period that is used. However, certain things may occur, bad weather where they can't get to a facility, for example, like they had planned, where this will allow some flexibility in the processing of products. Moving on to page 4. You'll see the first of 2 new sections that are proposed to be added to the chapter. Under state law, a minor is defined as an individual under the age of 19, and a parent or legal guardian is to sign their application. What this new proposed section does is provides information related to those individuals that reach the age of 19 who no longer have a parent or a legal guardian. They may have had a legal guardian until they were 18, and then the courts removed that legal guardian. We'll be able to jump ahead here all the way to page number 10, and feel free to yell out if you have questions. Sometimes I miss a hand raised in these meetings, and apologize in advance if that happens. But on the bottom of page 10, the changes here are made that allow the department to provide the materials to dispensaries to have them posted in the facility, whether that's certain education materials or possible recall information, to ensure that what the department wants posted in a dispensary does actually get posted in those entities. On the bottom of page 11, we're proposing making changes to what materials can be used to incorporate into medical marijuana waste prior to transporting it to a landfill. We'll be able to skip ahead to page 17. And you'll see on this page, language is proposed to be added to make it clear that violations of state laws and rules by a manufacturing facility or dispensary are to be reported to the department. I had mentioned that we had 1 or 2 new sections to the chapter that we are looking at adding. The second of those is on page 18. And this relates to medical cannabinoid products being made. The term medical cannabinoid products, what this would include are product types, capsules, lotions, roll-ons, and cannabinoid solutions. Used to be called tinctures in the program. We now call them cannabinoid solutions. This new section requires information to be provided regarding the other ingredients a manufacturing facility is using and that they're adding to the product. Mainly so we're able to ensure that the expiration dates are appropriate. What we don't want to have happening is an ingredient they add has a 6-month expiration, but the expiration on the product is a year. So just to make sure that our expiration dates on labels is appropriate. Next on pages 19 and 20, you will see very similar changes being proposed multiple times, as the same changes relate to the various products in the program. One change that I would point out to the council members is the requirement to add to the labels on products the type of extraction process that's used by the manufacturing facility. This will then allow qualifying patients to know what, if any, solvent was used during an extraction process. If you scroll down to page 21, there is language here to be eliminated. This language is being removed due to a change in state law from this past legislative session. The legislature did increase the number of designated caregivers that a qualifying patient may have from 1 to 5, with the potential of up to 5 individuals, and changes with caregivers occurring. We no longer have a caregiver's name being printed on the label. Finally, the last area that I would cover goes all the way down to page 34. And here you're going to see a couple of changes. The first change relates to how THC is defined. This change is also being made due to a change from this past legislative session where state law added a definition for THC. So we're just making the rules match up with what state law currently says. In addition, the information proposed to be removed relates to having the concentration amount identified by the lab that the Department of Health has under contract go onto the label, which is the current practice that we do follow. So just matching up the rule to the current practice. Council members, I know I covered a lot of information there very quickly, but I am happy to answer any questions you may have.
So, Madam Chair, this is Daryl, and I have, first of all, a comment and then a question for Jason. It doesn't necessarily relate to these changes, but you know, for all the work that you guys did a few years ago and drafted these regs, actually, it's nice to see that you only have a few changes that you've needed to make, even though you developed all these in their infancy of the program. So kudos to that. I'm just wondering, Jason, is there any measurement of any clinical metrics, or is there any outcome measurement to see whether or not the medical marijuana program has been effective for patients and what difference it's making for providers, et cetera?
Madam Chair and council members, I think the short answer would be no, at least for the state of North Dakota. You're going to see, if you go out and start Googling and researching and seeing information, you'll see surveys being used. Certain states have used some surveys to try to see how the products are working for their patients. A couple of years ago, we started looking at a survey, and when COVID hit, the people that help us with administering surveys, their time got pulled into several different directions, so we haven't moved that way. Some of the industry is considering, some type of survey to determine, satisfaction with products, or looking for more of that information. But right now we don't. And it kind of comes to with the Department of Health and the Division of Medical Marijuana, really our main role is a regulatory role. And sometimes that's more of an industry area that we see in some other states, but it is something we are considering. It's, I would say, on the list of things that we discussed occasionally, but at this point we haven't gotten there.
Thank you, Jake.
Mark has his hand risen.
Yeah, thank you for this. It's follow up on Daryl's question is, do we even have numbers in terms of publicly available numbers in terms of number of patients, number of providers dispensing, or I should say prescribing, and then any of that information, is that publicly available, at least as a starter of understanding of how this has been implemented?
Madam Chair and council members, the first thing that I'll make sure council members are aware of is that Mr. Strand used what we say is the P word. And I don't mean pot, I mean prescription. Under this program, there are no prescriptions from the healthcare providers. And a healthcare provider can be a physician assistant, or an advanced practice registered nurse. That's who state law authorizes to sign written certifications. In relation to the data and information, I would point to our division website. If you go to the Department of Health's website, our Division of Medical Marijuana website has an annual report. In that annual report, and I should back up, if our Division of Medical Marijuana website has the patient number that we identify. For example, at the beginning of February, we were at 7,151 cards. But if also there is a link to annual reports. So every year we do, at the end of every fiscal year, we do produce an annual report. In there, you'll see the number of healthcare providers, just the total number. You'll also get information in regards to the medical conditions that the healthcare providers had noted on the written certifications and other information about the program.
Thank you. I'm seeing that now. Very helpful.
Any other questions for Jason? If not, does somebody want to make a motion to accept the changes? And before we do that, Allison, is this a roll call vote or is it just aye and nay?
Substantive vote, so it's roll call.
Okay. And so I might need help actually knowing who's on the roll. I'll try to figure out. Okay, so do we have a motion to accept the changes to the medical marijuana article 2033-44?
I'll make that motion. This is Kevin.
Thank you, Kevin. Do we have a second?
Dan, I'll second that.
And then is there any further discussion or information that you want changed or brought to Jason's attention? Any further discussion? Any further discussion? Okay, we have a first and a motion and a second, and I will try to go down this list and see who's actually on the members. So, Kevin?
Yes.
Carrie?
Aye.
Missy? We're not hearing you.
Sorry, yes.
Okay, thanks. Daryl?
Yes.
Mark?
Yes.
Dan? I'm not hearing you either, Dan. Yes, Miranda.
Printed. If it's easier for you, I can go down.
Oh, that
for
would
the
be
next
awesome.
row.
Thank you. If I missed anybody, that would be awesome.
Sure.
Dan, did you vote?
Yes.
Thank you. And then Mary. Miranda, did I miss anybody besides myself?
You know, I have them in order, so I don't know that you missed any because it was a short answer. I don't know.
Okay. And I will vote yes. So I had 1, 2, 3, 4, 5, 6.
There should be 8.
Yep, that's what I had. Perfect. Motion passes.
Thank
And
you.
next time I'll let you read them. That will be helpful. Thank you. All right. Thanks, Jason, for all your hard work. We will go over to Vital Records now to Darren. Hi, Darren. It's good to see you again.
Hi, Sherry. How are you? Can you hear me?
Yes, thanks.
So, good morning, Madam Chair and members of the council. My name is Darren Meshke. I am the State Registrar and the Director of the Division of Vital Records at the Health Department. Just for some general knowledge, the Division of Vital Records is required by law to register and certify all vital events that occur in the state. These include births, deaths, fetal deaths, marriages, divorces, and abortions. We also provide statistical services based on these vital events that we register. I'm here today to talk about some proposed changes that we have to our administrative rules under Article 33-04. The first two are really just cleanup changes, basic updates to the rules where we don't do certain things based on our current practices anymore. The first of these is in Chapter 3304-01-02. And again, basic updates to the records and certified copies because now we process these electronically. So we don't use typewriters anymore or non-fading black ink to produce certified copies or register records. So the wording under subsection 1-02 is just being updated to address our current practices of electronic registration. The next change is to 33-04-15 regarding our fees for the services that we provide. The fees were updated as part of the Health Department's budget bill in the 2019 legislative session. And these changes need to be updated to reflect the changes from that session. Birth records went from $7 for the first copy and $4 for each additional copy to $15 for each record that we issue. And death records went from $5 for the first copy and $2 for each additional copy to $15 and $10 respectively. These fees seem like a big jump, but they weren't updated since 1985. So it was like a 40 year update there. So the final change that we have to our proposed rules are relating to the registration of an unattended home birth. The proposed changes that we're making add a new section of rule to 33-04-04 as subsection 2. So when a birth occurs outside of a hospital setting, my office is in charge with ensuring the 3 primary facts for birth registration. And those are that the mother was pregnant, that the child was born alive, and that the birth occurred in our state. Now, many of these home births are attended by a lay midwife, and in some cases, an actual physician. And it's not these births that we're concerned about. The ones that we're concerned about are the ones that only the mother or only the mother and father are there. Our lay midwives do an excellent job of registering these events and provide us all the proper paperwork for the validation of these 3 facts. They are, in fact, attesting to those 3 facts and are basically a general neutral witness to the event. So when a midwife or a physician is present, we don't have any concerns about whether the event took place in our state and the fact that it should be properly registered. The rules that we're proposing basically deal with the events, again, like I said before, where the mother or father are only present at the birth. Without a neutral third party at the birth to witness the birth, we just need some extra proof that the mother was pregnant, that the child was born alive, and that the event actually happened in this state. So included in your handouts is a draft document of required documentation for filing an unattended home birth. And you can kind of see the documentation that we'll be requiring to ensure those 3 facts of birth so that we have a proper registration of an actual live birth. Many states already have similar requirements in place. So we're creating this first draft of these documents based on what other states are requiring. The required documentation document will be maintained within the Division of Vital Records and can be updated then when we feel that any new documentation can be added to any of the 3 categories. Because again, this is a first draft, so we don't expect it to be perfect right out of the gate. The language then also says that if the parents are unable or unwilling to provide this additional documentation, then we will not be able to register the birth, and their only option would then be to go to court and have the birth registered through what we call a judicial determination of birth. Now, this process already exists under Century Code and Chapter 32-37, establishing date and place of birth. So while we will do everything in our power to assist the families with this new process within our division, if they cannot satisfy those 3 primary facts of birth without the proper documentation, then the court process is going to be their final option. Now, again, these changes are not meant in any way to discourage home birth in any way. We're only adding them to ensure the proper factual registration is then occurring. I kind of went, like Jason, I kind of went fast through all of that stuff. So if there's any questions, I'd be happy to stand for any questions, Madam Chairman.
Are there any questions for Darren? So
I had a question.
Yeah.
So the proof of residence, what if they're from out of state and they're here visiting and, you know, they don't actually live here, but they have to provide proof of residence to understand that the baby was born here, but I don't understand how that's helpful.
Madam Chairman and members of the council, that's a good question. Missy, what we would do in that case is wherever they're visiting, if they're visiting relatives or if they're visiting, you know, some other place we would ask for documentation from that resident, you know, maybe an affidavit from the relatives to say that, yes, these persons were traveling through North Dakota and they had the baby at our home.
Okay, thank you.
And Mark had his hand up, is it?
Yeah, so I'm wondering about what happens in the circumstance where a parent doesn't want to. You know, let's imagine that they, for some reason, so then a kind of a child without status or without recognition, and then what state would that child be considered to have been born in? And I mean, I'm just curious. We have these requirements, but then what if somebody just wants to ignore it? Or is that outside your responsibility?
Madam Chairman and Mark, another good question. So what we do have a process for registering births after the fact. We call that a delayed registration of birth. So what happens then is that eventually they will still have to come up with the documentation to prove that they were born in the state. It just happens after the fact. That's why we call it a delayed registration. Now, if they're completely abstinent and do not want to register the birth, we can't really force them to do that. There are sections of law that require this to happen, and they can be charged with up to an infraction within our rules. We never really have gone after anybody to do that. We again try to be very helpful with the parents. And what typically happens, and I'll just give you an example, is that when they refuse to do it at the time of birth, usually then what comes around is school registration. And you have to have a birth certificate to get registered for school. So at the age of 5 or 6, or whenever they're going to go into kindergarten or the first grade, they will go through that delayed registration process and basically have to provide the documentation that we're asking for at birth, so that we can file what's called the delayed birth certificate. That's usually what happens in those cases.
Thank you.
Kevin?
Yes, my question is directed to how many, as far as the data on home births that you have on an annual basis that, you know, where we get the data?
Madam Chairman and Kevin, that's another great question. We typically register about somewhere in the neighborhood of 100 home births a year. That number is rising over the past few years. But as I mentioned in my comments, the ones that are attended by a lay midwife or a physician are a substantial number, a substantial portion of those home births. We're probably only talking about 15 to 20 of these births that are unattended annually. So it's a very small number of births. But the changes that we are proposing put into place an added barrier to fraud. You know, we don't really have anything in place for that right now. If somebody, you know, just fraudulently wanted to make up a person, it would be much easier to do that right now with the rules that we're putting in place to provide this documentation. We're getting a little bit of a handle on that fraud issue.
And I think Carrie had her hand up as well.
Yeah, I just have a question for you about the location of birth, because, you know, down in the southwest corner or right on the border and everything. And so is it where the house resides as North Dakota, or is it their address that's considered the place of
Right,
birth.
right, Madam Chair and Carrie, and it would be where the actual house resides. It would have to be in the borders, within the borders of North Dakota. The registration of vital events happens in each state. There's a vital records office in each jurisdiction of the United States. So wherever a birth is occurring and actually happens within the geographical border of the state, that's the state where the birth is registered. Just a side note on that as a follow-up, say a parent was anticipating having a home birth down on the South Dakota border, and something went wrong, and the midwife said, okay, let's call the ambulance. The ambulance comes, the ambulance takes that South Dakota resident, say to Dickinson, for example, and the baby is born in transit in that ambulance. So the baby then, even though the mother went into labor in South Dakota, because the baby was born in transit, it's where that baby is removed from that actual vehicle. So that would be a North Dakota birth in that example. The same if a baby was born on an airplane and it was flying into North Dakota, it's where that baby comes off of that moving conveyance. So that would be a North Dakota birth if it landed in Bismarck.
Great discussion. So you said this was a draft, but do we then still vote on the changes, or how does that work with this one?
Madam Chairman, the rules are not draft. The document that's in draft is that extra document of documentation that our office will use to help the parents provide us with the three forms of documentation that we will be requiring.
Perfect. Thank you. So with that, and are there any more questions first for Darren? Okay. If not, will somebody make a motion to accept the changes to Chapter 33-0404 and 16?
Missy, I would make that motion.
Thank you, Missy. Is there a second?
Mark Strand, second.
Thank you, Mark. Any further discussion? Any further discussion? Any further discussion? And if not, I will then turn it over to Miranda to do a roll call vote.
Okay. Sherry Adams,
Yes.
Daryl Birch,
Yes.
Daniel Churchill. I'm sorry, what was that?
Yes.
Kevin Dufany,
Yes.
Mary Gumke. Mary Gumke,
Yes.
Missy Hankey,
Yes.
Carrie Ann Ranum,
Yes.
Dr. Mark Strand.
Yes.
8 yeas, 0 nays.
Thanks very much, Miranda.
Thank you, Madam Chair and members of the committee.
Thanks, Jason, also for your hard work. And we will go to the next line item, which is the state loan repayment program. And we'll turn it over to Kaylee Werner.
Morning. Can you guys hear me?
Yes.
Good morning, Madam Chairman and State Health Council members. So the first one on our agenda is actually the Veterinarian loan repayment program. So Dr. Beth Carlson will be presenting the applicants and the recommendations. Is Dr. Carlson on?
Yes, I'm just going live here. Good morning. Thank you all for having me here. This is kind of fun. I think that Dr. Ranum's mother-in-law was my piano teacher when I was growing up. So it's North Dakota. That is my 1 degree of separation. So we didn't have very many applications this year. We were kind of a little bit surprised and maybe a little disappointed, but we did have some good candidates, some of the quality of application as far as how well they filled it out was a little disappointing. But there was a pretty clear break when they were scored. And so our top three were Dr. Hansen, Dr. O'Neill, and Dr. Vallis, actually in the order of Dr. Vallis, Dr. Hansen, and Dr. O'Neill. Dr. Wohler is still a student and didn't have as strong of a tie to the community. And I think that was the primary reason why she maybe wasn't selected. She didn't have a lot of community support or ties or commitment there. So probably would be a good candidate going forward if she were to reapply in that area. So if you agree, I would entertain your support for those three candidates.
Thank you. So because a lot of us are new, is there some way to just kind of do an overview of how this process works?
Oh, sure. I apologize.
No, it's okay.
So typically the veterinarians apply. Usually they already are in a community, or they can apply for a community where they intend to start practice within the next 6 months. And they submit an application which basically outlines their, they write a letter showing their commitment to serve in that community, some letters of community support, and then also some professional references. And then the scoring system, which was a setup, we have a standard score card, which places weight on each of the points that were specified in the law, gives additional points for smaller communities, does take into consideration, though, that, for example, one of our candidates this year, their practice location is Mandan, but their practice area is huge and covers, a large segment of the south central part of the state, including all of Sioux County, which is certainly an underserved area. And then the points there's additional points for food. It's focused on food animal service because that's the most difficult area to provide service for. Provides a little bit of kind of what we almost call bonus points if they provide auction market service, because that's an area of the state that's really critical for animal health, traceability purposes, livestock health, and it's often hard to fill those positions. And then we have a subcommittee of the Board of Animal Health, which reviews those applications, makes a recommendation to you guys, and then you guys, sometimes you have a few questions, but typically we'll vote to approve those candidates. I don't recall a time when those candidates weren't supported. Once in a great while, we'll have a change. So we'll have a previous recipient that maybe has left their practice area, and then we'll bring that to you to determine whether or not that veterinarian should be allowed to continue to receive funds, even though they're not in the same area where they originally applied. But this year we don't have any of those. We just have these four new applicants. Excuse me. 4 new applicants that we can choose up to 3 for to receive up to it's a total of $80,000 over 4 years, up to $15,000 the first year and the second year, and then up to $25,000 each year, the third and the fourth year.
Thank you. That was a very, very good description. Okay, so any other questions before I ask somebody to make a motion to choose 3 of the 4 based on Dr. Carlson's recommendation? I know this is important. I have 3 dogs, so I'm very much of a pet lover. Any other questions before we ask for a motion?
I guess what are the 3 columns, and then what's the red column in the report? You gave a general overview of all the categories, but what do the columns represent? I'm not sure why there's no headings, and then there's a red column that suggests something.
Sure. So usually, and this is just policy, it's not the requirement, but usually we have 3 members of the Board of Animal Health who score those applications. And then the 3 veterinarians that work for the State Board of Animal Health in the Department of Agriculture, myself, Dr. Anderson, Dr. Bailey, we will score the applications, but we'll average our 3 scores. So our vote is 1/4 of the total as a group. And then the 3 members of the board, and then we average those 4 scores. This year, we had originally scheduled the evaluation to occur on a day when we had some adverse weather last week and we weren't able to have the in-person meeting. And one of the members of the board just really struggled with getting those done remotely. They had trouble opening the files. And by the time we realized he wasn't going to get them scored, based on the way the scoring came out, it would have been extremely unusual if his score would have swayed that outcome. And so we just didn't have a fourth score. So that red is just, there was no score for that board member. But again, that wasn't necessarily a requirement that we have 4 scores. That's just been policy. So.
Thank you.
All right. So based on that, will somebody entertain a motion to bring forth 3 names to vote on? We'll do that first.
So moved. Mark Strand.
What did you say, Mark?
Wasn't I making a motion to approve those 3 names?
Well, we have to choose 3. There's 4. So based on Dr. Carlson, the top 3 were Macaulay Vallis, Matt O'Neill, and Dalton Hansen. Those were the top 3 choices, but the other one was Bianca Wohler. So I think we have to choose 3 of those 4.
Okay, my motion was to choose the top 3 as proposed by the scoring committee.
So we have a motion to accept the top 3 choices as presented by Dr. Carlson. Do I have a second?
I'll second that. This is Kevin.
Thank you, Kevin. Any other discussion on this? Any other discussion? I'm going to have to refresh my Robert's Rules of Order as well. So any other discussion? And is this also a roll call vote? I thought so. Okay, I will turn it back over to Miranda, who did such a nice job the last time.
Sherry Adams.
I vote yes.
Daryl Birch.
Yes.
Daniel Churchill. I'm sorry.
Yes.
Thank you. Kevin Dufany.
Yes.
Mary Gumke. Was that a yes?
Yes.
Dr. Hankey? Dr. Hankey?
Yes.
Dr. Ranum?
Yes, sorry.
Dr. Strand?
Yes.
8 yeas, 0 nays.
Thank you. Thank you, Dr. Carlson. And I'm glad to see individuals still continuing in the veterinary field.
Yes, thank you very much. Appreciate your guys' support of the program.
Okay, we will go back to Kaylee Werner and turn it to healthcare professionals.
Thank you, Madam Chairman. So in your packet, there was a couple of individuals that have received loan repayment and are requesting a site transfer. There should have been 3. One is determined ineligible as a profession, I guess, moving forward, that she's transferred to a different position. So the 2 that are up for review are Dr. Rachel Morrell. She is originally was awarded in Williston at Great Plains. She has since moved to Bismarck and is requesting continuation in the loan repayment program. So you should have that letter. And then the other individual is Jennifer Goldaddy. She has transferred sites as well and has moved. She is a licensed addiction counselor and she has moved to Heartview in Bismarck. So just requesting if we have permission to continue them in the loan repayment program.
And that should be we'll bring that forth easily, but can you also kind of do just like a brief overview of what that program entails for this group?
Sure. Yep. So the healthcare professional loan repayment program is a 5-year program that is state funded. We offer physicians, dentists, behavioral health professionals, and then of course the veterinarian loan repayment that you just saw. So all of those folks are underneath, and then the advanced practice, so advanced practice. So all of those are underneath the North Dakota healthcare professional loans, the physicians. It's awarded in priority. So the areas according to Century Code, and I'm just going to pull it up here. The North Dakota Century Code, the criteria for eligibility meets the selection criteria, is located in an area that is statistically underserved and is located at least 20 miles outside the boundary of a city having more than 40,000 residents. That's the eligibility for participation priority. So it's not, doesn't have to be, but that's the priority that are given to these individuals. So each year, the number of slots kind of changes depending on the biennium. This last year, we funded 3 physicians. Dr. Rachel Morrell was one of them. And then the healthcare professionals also vary. So last year we had 7 slots. The awards are $100,000 for physicians with a $50,000 community match. For behavioral health professionals, it's $20,000 with a $2,000 community match, and that's paid out over 5 years. And so when we select them, priority is given to those serving in underserved areas. But like I said, it's not mandatory. It's just a priority is given to those. And so these individuals have moved sites and are requesting continuation in the program.
So I guess one question I do have is that if they have originally signed up in a lower, population area and then move into bigger cities, is that a problem down the road? I mean, do we see that a lot or?
So I'm fairly new. I've just been here a year. And I guess what I've seen in the last year is we've just had a few that have moved to more of the urban areas. And the ones that I'm presenting are those individuals. We did have a couple defaults as well. We've had 3 defaults, meaning that they no longer fit the criteria or eligibility for loan repayment. So we've had 3 defaults in the last year.
And then Mark had a question. Thank you, Kayla.
When you say default, does that mean they have to pay back prior money, or do you just no longer give them money moving forward?
Right, no longer give them money moving forward.
And then second question, if we have those individuals who request continuation, even though they've moved into a setting where they may be not ineligible, but lower priority, are they in any way competing with other new incoming persons who are applying, but then not getting the opportunity because these other persons have already occupied those repayment plans? Or is the number of persons who can participate sort of unlimited?
So, excuse me, it's 3 a year. So for those that are moving sites, those funds are already allocated. So if we're having them move sites, they're not taking away from additional funding moving forward. So the next cycle, which will close here March 15th, those will be 3 new physicians that will be awarded.
Thank you.
Good question. Yeah.
Mary,
Yes.
Oh, go ahead, Dr. Reno.
I said, I guess one thing that I worry about with going ahead with people applying in rural sites and then going to a bigger city is that this is going to end up happening more on in the future, where they only fulfill a 2-year and then they get the 5-year loan repayment. That's my only concern.
And I think that was kind of my concern as well, but I'm kind of new in this whole thing, that where the gaps are, the rural areas. And so that was my concern as well.
As a follow-up.
Yes, go ahead, Mark.
I was going to say, I have the same concern, but per Kaylee's prior response, they're not taking away opportunities from others. Is that correct? So it's, they're in a prior cycle. So as long as the money, I guess what I'm saying is maybe it misrepresents the program. So then people assume, well, they're so soft. Every time I can just go out to a rural site for a year and then transfer in and I can get 4 years of payment. I mean, that would be the one. Is that what you're thinking, Carrie, as the biggest risk?
Yeah, I'm thinking that.
Kind of
That's what,
contaminating the purpose of the program. Okay.
yeah,
That's all.
yep.
Question about Jennifer Goldaddy. So she was already working at West Central, which is within Bismarck. So For eligibility to begin with, I'm a little confused.
Sure. So they award, so in the state as well, there's HPSA locations, so health professional shortage areas. So our service centers and zones qualify as a health professional shortage area. So those are high priorities in our state to get the healthcare professionals into those positions and into those organizations. And so that is, and I wasn't here when she was funded, but I believe that's why her application was chosen, because she was working in a health professional shortage area.
Thank you.
And Kevin, you had your hand raised. You're on mute.
No, I didn't have my hand raised, I don't believe, unless I bumped it.
Okay. Daryl.
So I think in prior years, we had discussion about this as well, when folks would end up moving from one location to another. And I think part of the due diligence that was done in the past was to see if those services that are provided then in Bismarck or wherever are still available to the rural folk, because there may not be rural access to some of those services. So, that was part of the consideration when these requests for relocation and continued approval took place. Again, as long as they're practicing in the same profession and doing the patient face-to-face and et cetera. And I agree with both Dr. Random and Mark's comments, is we don't want people migrating from rural to urban and just abusing the system. But, hopefully we can, as a council, we can manage that appropriately in the future.
Thanks, Daryl. And I see that helps with your expertise being on here before. So thank you. And then I see Kelly has her hand raised.
Morning. Hi, Kelly Nagel. I'm the director of the Office of Systems of Performance, which is where the primary care office lies. I just wanted to add that in Century Code, it defines, it indicates that it's the defined areas of need, and it does not require that it be in a HPSA or healthcare professional shortage area. So that is one of the reasons why they are awarding professionals that are in urban areas. So they may be determining defined areas of need based on if the professional is a specialist that's needed in that area. In this case, it's in probably in a behavioral health area where there is needed professionals. So I just wanted to make sure that that is noted.
Thank you. And this is good discussion, especially for those of us that are new. So it's good to understand how the whole process works. Are there any other questions before I ask for a motion? Any other questions from anybody?
Sorry,
Yes.
my quick question is just you with the physician, the provider one, it's 100,000 over 5 years with a community match of 50,000. So does Bismarck acquire that other 50,000, or has that already been paid by Williston?
No, Williston had paid 16,000. So Bismarck would be required to fill the rest.
Great question.
Have you gotten that letter of support then from the community?
No, not yet. We wanted to bring it forward to the State Health Council for approval before we moved forward with having her secure a community match.
So this may be similar to the minutes of the last meeting that reflected, I think it was Senator Roars that brought up that any approval was contingent upon you receiving that community support to have happen, correct?
Yes, correct.
And I think we can put that as part of the motion, if somebody would like to now make that motion. Anybody want to make a motion to approve these two?
So again, the recommendation that was brought forward was what? Kaylee, can you just re-highlight the recommendation?
Yes, so both of the providers Dr. Rachel Morroll and Jennifer Goldetti have transferred sites, and they're just requesting continuation in the loan repayment program. Dr. Morroll is a first, so last year she was awarded, so 2021. She has not been paid yet. She'll be paid June of 2022. And Jennifer started in the program in 2019. So just requesting permission for continuation in the program.
So I would move approval of your recommendation pending your receipt of community support.
Thank you. We have a motion on the table. Is there a second?
Missy, I would second that.
Thank you, Missy. Any other further discussion? Any further discussion? Any further discussion? Okay, I will have Miranda. Looks like she's locked up, but I will have Miranda do a roll call vote.
Sherry Adams,
Yes.
are you still able to hear me?
Yes.
Yes.
Now you're moving. Yes, I vote
Okay.
yes.
Daryl Birch,
Yes.
Daniel Churchill,
Yes.
Kevin Dufany,
Yes.
Mary Gumpke, Mary Gumpke,
Yes.
Dr. Hanky,
Yes.
Dr. Ranum,
Yes.
and Dr. Strand.
Yes.
8 yeas, 0 nays.
Thank you, and thank you for that good discussion and clarification.
Yes, much appreciated.
Thank you, Madam Chairman and Council.
And no matter how you look at it, we have a medical shortage, so it's good we still keep them in North Dakota. And the last agenda item I have is Dr. Wiebe.
Yeah, thanks, Sherry. And so I'll kind of provide some of the updates. Oh, let me share my screen also. Hopefully it is working. Working? Okay, perfect. So I would, thanks for the opportunity to provide some of the updates from the Department of Health perspective. And this, I'll take a few minutes and provide some of the updates, meaning some of the successes and some of the milestones that have been achieved by the Department of Health over the last couple of years. I'll also provide an overview on the integration work between the Department of Health and the Department of Human Services, and some of the design or redesign in the organizational structure that we have done within the Department of Health. But first of all, I want to kind of reflect for a few seconds. So this today, I have completed 10 months in my position, and it has been really so great to join a fabulous team in the Department of Health. And all the work and the response that we had in the last 2 years for COVID is due to the expertise and dedication of all our team members. And I know there are many of them on the screen. If you can just turn on your camera and wave, team members. So they have been on kind of like overdrive for the last 24 months. And this has been reflected in the well-prepared and well-planned response that we had for COVID. So thank you for the team, and I'm really very proud to have joined the department. So with that, I'll move to sharing a few of these successes that we had. I'll start with a few items that are not COVID related, and then I'll focus a little bit on COVID. But we were recognized on a national level as a registry of excellence from the CDC. And that has been a great honor and a great recognition for the level of work and quality that we have provided. Also, we have maintained our national accreditation. That's through the Public Health Accreditation Board. We are the only Department of Health at a state or a local level within the state of North Dakota that has achieved such accreditation, and we are in the process of applying for reaccreditation for the next 5 years. And of course, the last couple years where we were kind of like focusing 24/7 on the pandemic response, and that included from education to testing to vaccination to therapeutics to all other aspects of even providing additional healthcare professionals to support the various missions across the state. If you are interested in more kind of like concrete achievements and numbers that are not COVID related, NDQIT's cessation has counseled 26,000 patients in the last 2 years. We have conducted 7,200 inspections of licensed facilities. The WIC program provided healthy food and support to over 32,000 women, infants, and children. If you have heard of the AED project that was implemented the last couple of years, it resulted in the distribution of around 1,600 AEDs to law enforcement partners. And Women's Way screened more than 2,000 women for breast cancer and or cervical cancer. Moving to COVID response, again, I mean, the numbers are beyond fathom here. But there has been a total of 3,000 COVID tests that were conducted, of 3 million tests. Our teams for contact tracing have completed more than 300,000 contact tracing cases. Around 1 million vaccine doses have been administered. And 1.4 million tests were processed through our lab. And most of these numbers are to the end of the biennium, and the work and the response to COVID has been ongoing through today. And the latest is that we have acquired 2 million home-based testing kits that will be provided to our citizens for free. We have already received 1 million. We have pushed 500,000 to various locations around the state for our citizens to pick up and do their COVID testing at their convenience, at their home or wherever they choose to make sure that they make a well-informed decision based on the results of these tests, avoiding crowds, staying at home, so then to contain the spread of the disease. So I'll shift to a few words related to our merger or integration between Department of Health and Department of Human Services. But one thing that kind of like allowed us to use, based on the work that was done in 2021, was the strategic plan for health that I know required and it took a lot of work, a lot of resources, a lot of effort by many across the state to articulate our vision for health in North Dakota. And simply put, it is the vision for North Dakota to become the healthiest state in the nation. This will require strengthening the infrastructure and become more responsive and supportive of health and well-being initiatives across the whole state. So when we started looking at this merger or integration between Department of Health and Department of Human Services, we used this fundamental guiding principle as the way to bring both agencies together. We thought that, both Department of Health and the Department of Human Services can agree, and they all are working at this point separately, but eventually as they come together, their focus will be and should be on North Dakota becoming the healthiest state in the nation. And for this purpose, we also devised specific goals that will help us to focus the work that we are doing when it comes to integration. The first of these goals is that we want to have one streamlined path to quality and programs and services, meaning that as it stands now, many citizens, many North Dakotans, as they are seeking services, they might need to go to different locations or different offices to seek their services. And these offices or locations might be Department of Health, Department of Human Services, Behavioral Health. And we want to make sure that we make it much easier for our citizens to go to one location, streamline services, and ask and receive all what they need of services. We also want to improve quality, effectiveness, and efficiency of the services provided. So this is, again, another goal that as we bring these two agencies together, we make sure that we achieve this improvement in quality. And the third one is more specific and focuses on our team members. We want to provide opportunities for growth and development. As we bring two teams together to become one team, we want also to make sure that there are opportunities for our team members to grow and develop. And in order to achieve that, we want to leverage our strength, meaning that we bring the best of both worlds. So whatever is working best in Department of Health or Department of Human Services is what we adopt. So we leverage our strength. We want to add more value, meaning enhancing quality, enhancing effectiveness, enhancing efficiency in the services we provide. And a fundamental piece here is that we need to embrace and be open to innovation, new ideas, new ways of doing things. Also, many of you might know that we have engaged Deloitte as our consultants to help us through this process. And as you see, this process started in September of 2021, and it's not meant to I will not bore you with all the details, but if you look at the top, September of 2021, that's when the process or the engagement and the work has started. With a date of September 1st is the official date when both Department of Health, Department of Human Services come together to create a Department of Health and Human Services. And we are almost like midpoint here in March. So there has been a lot of work that has been done the last several months. We are now in the design phase, and that is more focusing on how to design this new organizational construct of the DHHS that will happen. So since we are in the midst of this design phase, we worked on a couple of org structures that are at very high level. I would like to share with you for informational purposes. So I'll share with you in a couple seconds. There is still one item that I want to reflect on, which is that by design, as we are bringing these two agencies together, we wanted our leadership teams as well as our team members to be involved in the process and in finding ways of how we work together and what would be the best construct or the best way, best path for each service or for each business support service also to work. So we had devised 6 work streams. Again, I will not bore you with the details, but we found that communication, finance, HR, IT, operations are the business support aspects that most likely or that will be brought together from DOH and Department of Human Services. And we included our team members and leadership to work on these work streams and to see how they best should look like in the future organization. Of course, the program integration in the bottom is more focused on the programs itself and what specifics between Department of Health and Department of Human Services that could be complementary or could leverage one another. So effective September 1st, 2022, this is the new org structure that will be reflected within the Department of Health and Human Services. Again, it is a very high level org structure. There will still be 2 positions appointed by the governor, that what would be what currently is executive director of DHS would become a commissioner of Department of Health and Human Services. The state health officer position will still be a cabinet position appointed by the governor as well. There would be a deputy commissioner, and just kind of like to look at the orange boxes, there would be 4 to the left that are program focused. The Department of Health will become a division of public health, the very far left. The 4 boxes, the 4 orange boxes to the right are the business support aspects, which would be financial or fiscal, human resources, communication, and the legal piece. We have also kind of like in an attempt to streamline also the nomenclature of these units. We found that these 4 programs would be best described or titled as divisions. So this would be a division of public health, division of medical services, division of behavioral health, and division of family stability, which might also change the title of that. So this will be effective September 1st of 2022. So the next slide, I want to just share with you some additional changes that we have done to this very division to the very left, which is public health division, that will be called Division of Public Health in September. But as it stands now, it's still Department of Health. and in a kind of like also attempt for us as a Department of Health to kind of like streamline some of the services and kind of like put together some of the units that seem fitting together. We kind of revised or shifted some of the boxes to allow it to become kind of more agile and responsive, as well as to allow more grouping of the same focus areas or fields together. So I will not go through a lot of the changes, but I'll give a couple of examples, like, vital records, for example, and systems and performance. We found that they might fit better under health statistics and performance, because this is a vertical or a unit that is very data-driven. And we thought that bringing systems and performance, bringing vital records to this unit will make more sense. So the very far right side where it says administrative services, this eventually will be the arm that will be combined with the right orange boxes here. These are the support services, communication, human resources, and fiscal. As you see, there are 3 boxes. Each box will find its way to its bigger box within Department of Health and Human Services. This new structure will be effective April 4th, which would be 1 month from today. And again, the purpose of that is to kind of like make it to be better prepared and streamlined as a Department of Health and as a additional step as we enter the integration with Department of Human Services. So this concludes my presentation, and I will be happy to entertain any questions, thoughts, comments, suggestions. And I see Daryl has his hand up.
So Dr. Wiebe, just in general, again, I want to just lift you and your department up during these difficult times with the COVID pandemic. I know it's been a challenge, especially, there's different opinions out there about what should be done, shouldn't be done, but in any interactions that I've been involved in or observed, your staff has been nothing but professional and has done a great job through this difficult time. So I just want to lift you guys up from that perspective. When it comes to the strategic plan, is there a time when you plan to engage healthcare providers to help make North Dakota the healthiest state in the country, and or engage the residents of North Dakota? What are the plans from that perspective?
Yes, so Daryl, thank you for your kind words. I totally agree that our team is the most dedicated, most professional, and most experts in that pandemic response. As for your question, so the interesting kind of like timing of all these events is that we have a Department of Health with our team members having full-time jobs. Then you add a layer of COVID response, 24/7 response. Then you add a third layer of working on integration between a Department of Health and Department of Human Services. And as we kind of like, try to sort through these 3 layers of responsibilities, we will get to the point of working on the strategic plan and ensuring or kind of like operationalizing the vision of North Dakota becoming the healthiest state. And this will include bringing in stakeholders, because that is not only a Department of Health or a Division of Public Health or a Department of Health and Human Services. It will be, and it has to be, a statewide initiative. So stakeholders are integral part of that. And by stakeholders, it includes not only healthcare professionals, hospitals, tribal nations, local public health, of course, is one of our major partners. So as we kind of like, as they say, kind of like, to build really this great foundation, let's take it one step at a time. There are still no timelines that are in place, but we know that's where we are going, and that's the path that we have devised to achieve.
Thank you, Dr. Wiebe.
Sure.
Dr. Wiebe, there is a chat question from Kevin. If you would also send out your presentation.
Sure, absolutely. We'll do that.
And Mark.
Thank you, Dr. Wiebe. I'd like to add my, appreciation and respect for you and the thousands of public health professionals across our state. And to that end, is there it's sort of one technical and one more support-based. Is there a plan in the coming year to do a hot wash of our COVID experience in order to draw upon the best practices and lessons learned, especially from our frontline local public health professionals? That's from a technical side. And then from the more personal side, is there anything we can do to provide more moral support and kind of some way to communicate to all local public health and state level public health professionals in our state the respect and admiration for what they've done? Many of them have been under tremendous stress, in some cases duress this year. And I know that none of them will ever take even a weekend off to recuperate, much less an event, to provide that space to say your stress and strain is okay. So first question, technical hot wash, lessons learned, intentions. Second, is there a way, state public health professional appreciation day, or an event when we're all together, like at the Dakota conference, or some such event when we can tangibly look people in the eye and say, thank you. Thank you.
Yeah. Sure, Mark, thanks for these two questions. So with COVID, so let me just kind of give you a preview of where we are now with COVID, number of cases and hospitalizations declining. There has been a trend across the nation, as well as from the CDC, to kind of like now to modify the way we are interacting with COVID, because we now recognize, and we have recognized this several months ago, that it will stay with us. It will ebb and flow. It might be seasonal, might hit different parts of the country at different times, different geographies during different times. But the trend now is to, okay, now what can we do to live with COVID and minimize the burden on the healthcare system, as well as to minimize or contain the severity of the disease. And one of the actions that we have done, as I mentioned earlier, is that we have acquired 2 million home-based testing kits. And that is to expand our capacity and capability in testing, and to allow individuals, to allow our citizens to do their testing wherever they are. And they don't have to wait 2 or 3 days for a PCR test result, because in 3 or 4 days, they are already beyond the incubation time or the isolation period. And these tests will allow them to get a result in a matter of minutes. So the main message, again, is for our citizens is, if they are feeling sick, stay at home. Do not interact with other people, or do not go into crowds and spread the virus. If you want to have kind of like peace of mind and test and confirm that it may or may not be COVID, you can go to a local public health site or any of the other testing kits sites, pick up your testing kit, go back home and do your test. And based on the results, you can make your own decision of staying at home and isolating or quarantining from others. So as we are winding down these operations, that's when we'll be able to kind of reflect back on these 2 years of response and capture a lot of these lessons learned. We've been doing it kind of on and off, but when we are in a response mode, kind of like where 24/7 we are focusing on the response piece, it doesn't allow us maybe the appropriate time to reflect and capture all the lessons learned and start preparing for the future. But this is coming really fast as we start capturing these lessons, because guess what? We have to be prepared for the next COVID wave or for the next pandemic or for the next public health emergency. And it behooves us to collect all these lessons and expertise and experiences that we have gone through and become the fundamental units as we prepare for the future. So this is coming really very soon. As for the moral support, I think, we can start that when we see any public health professional or a healthcare provider, let's say thank you. I think that would go a long way and will allow everyone. Mark, you are on target. I mean, everyone in public health, everyone in healthcare system is stressed out and they are at the brink of collapse. A thank you is a good start. Whether there will be a kind of like a state day for public health professionals or for healthcare providers, I hope maybe we can work on something of that proportion to also reflect and show our gratitude and our thanks for all public health professionals and for all healthcare workers. Maybe it could be in one of the conferences, but let's start the discussion, let's start the conversation, and maybe we can find something that is really meaningful and reflective of how thankful we are of everyone who was part of this effort.
Thank you.
Mm-hmm.
And as a local public health person, I really do thank you for bringing that up. It warms my heart, and this was definitely a big team effort. So thank you, guys. I guess that's the end of the agenda. Do we have any? Yes. Did somebody else talk? Okay. So is that all we do now? Is we're finished? We just adjourn?
Yep, you just adjourn. You do not need a motion to adjourn a meeting.
Perfect. All right. Thank you, guys. This was very, very rewarding. And I think this is going to be a good team to work with over the next year or two. And I appreciate getting to know each and every one of you a little bit better. Some of you I know pretty well, but some of you it'll be good to get to know. Thank you, Allison, for all your support in getting me through this meeting so I can reread Robert's Rules of Order better. And I appreciate everyone on this call. I think we will all strive to work together. And the next meeting will be in about 3 months? We'll be sending out an agenda. Is it a quarterly meeting, I'm assuming? Is that correct?
I believe it's as needed.
Okay. All right. So we'll be sure and set that soon so that you at least save the date on your calendar.
Yeah, that would be a good idea. And I don't want to let this opportunity go by without thanking you, Sherry, for driving the bus, getting us to our.
Well, thank you. It's a good team, like I said. I think it'll be good to work together. For that, I guess you guys stay warm, stay healthy, and stay COVID free. that's our. So we always end our meetings by saying, stay positive, but negative on COVID. All right, you guys. Thank you very much for all that you do, and have a good rest of the day.
Thank you. You too.
Thank you, everyone.